So this lecture is basically a continuity to the previous lecture in which we discussed the different clinical pathologies that can end up in the pulmonary emergency departments. So when I use this word, the pulmonary emergency, it's basically the intensivists who would take care of the patients who are having difficulty in breathing, and to sustain the airway, to sustain the breathing and the circulation of such patients is very critical at this point. So you can really have a clinical picture in your mind that the patient is having a difficulty in breathing, he's coughing extensively, he has chest pain, and all of these features are present in the patient. Now, when you have this clinical picture in your mind, you must have a supporting history with you as well to make a particular diagnosis for this particular patient. Now, the age also matters over here a lot. Just focusing on the age of the patient would cut down a lot of differentials in your list. So just to focus on the age of the patient, if it is a child, you would be focusing on much rather a congenital abnormality that you're dealing with, and you would like to basically conduct some diagnostic tests just to rule out the factor that the child is suffering from some sort of congenital abnormality in the airway passages, and that is basically making the situation critical for the child. Then again, we have hypersensitivity, which is very common in the children. So this age group is more prone to the congenital abnormalities, to the hypersensitivity reactions, to the prolonged inflammatory kind of reactions that they can develop, which was basically categorized as the asthmatic conditions that we've already gone through. Then trauma is another important factor. A lot of patients would come up to you in this, belonging to this particular age group, with a history of foreign body aspiration. So this is something that you have to focus on the age of the patient, and this would make it more easier for you how to diagnose the particular clinical underlying pathology that the particular patient is suffering from. The middle-aged group has its own pros and cons, and again, the history is going to reveal a lot of factors. Sometimes this age group is already diagnosed with a particular kind of a disease. History of smoking is something that you would be asking from this particular patient. Then we'd be moving on to the history of presenting illness. How did the illness develop? Was it of an acute onset, developing within the past 24 hours, and before that the patient was normal? Or was it something that developed over a period of weeks or months that basically points out towards the chronicity of the disease that the patient can be suffering from? So again, the cough is somewhat a factor that you have to focus on. What is the kind of cough? Is it productive? Is it a dry cough? And then moving on, we'd be focusing on the associated features with cough. For instance, cyanosis can start developing with cough, and these are the two features that can go side by side. So you'd be asking about these associated features as well when you're taking the detailed history from the patient. And again, the environmental factors are also taken into account. So all of these factors one by one would reveal that what is the patient suffering from. Either it is a pulmonary embolism that you're dealing with, either it is the pulmonary arterial hypertension that you're dealing with. Is the cough related with hemoptysis? That is another wide variety of discussion, a wide topic of discussion that we'll be going through even in this particular lecture. That is basically focusing on cough, which is associated with the production of blood as well. So that is basically the sputum that is tinged with blood. Blood tinging in sputum is one of the criteria that we have to focus on over here. These are some of the signs and symptomatologies. As an intensivist, you must be well aware, you must be well versed with all of these conditions when you have these patients of pulmonary emergencies, and that is basically making it more easier for you how to diagnose these cases in a particular way. And obviously, then only you can make the treatment modalities and the treatment plans accordingly for these particular patients. Now, as we were focusing, we have this condition which is known as the acute pulmonary embolism. Starting off again with the history of the patient. History is going to reveal a lot of factors over here. For instance, the patients who are suffering from the acute pulmonary embolism would have this particular history that they have been bedridden for a prolonged period of time. And you would be basically looking for the features of DVT, that is the deep vein thrombosis. If they are likely to suffer from the deep vein thrombosis, the thrombotic phenomena that is basically occurring in the deep veins of the leg, and especially the calf muscles are affected through this particular condition of the deep vein thrombosis. How does it occur? What is the underlying pathology of deep vein thrombosis? It is again very important to focus on the fact that usually the patients who are post-surgical, they went through a major surgery in the recent past. That is basically you're going to focus on the 90 days, almost 3 months criteria has to be kept in mind. The patient had been bedridden due to any cause, whatever the cause is. Was it a trauma? Either it was any major surgical intervention that the patient had undergone, and that led to the immobility of the individual. Now, this immobility of the individual can subsequently give rise to the thrombotic plaques that can occur in the intimal layer of the vasculature of the calf muscles. Now, this thrombosis, when these thrombi are formed in the peripheral circulation, they can get dislodged at any time. They are basically this is something that can basically give rise to the pulmonary emboli. And when these thrombi, they get dislodged from their particular places in the peripheral circulation, they get involved in the pulmonary circulation, and when they reach the minute capillaries in the pulmonary, in the lungs, in the vicinity of the lungs, they can give rise to dyspnea, they can give rise to difficulty in breathing. So this is the whole cycle of events, the cascade of events that can lead to this very critically ill patient who's having difficulty in breathing. And again, the diagnosis is very important over here. What are the particular lab investigations that you would be having at your hand is again very important. You're going to focus on the Doppler's ultrasound, and that is going to reveal a lot of factors. For instance, the Dopplers of the leg is going to reveal whether the patient is suffering from some sort of a DVT or not. Is there any compromised vasculature in the peripheral circulation or not? That is basically giving rise to the emboli, and the emboli then can finally reach up into the pulmonary circulation, leading to this whole scenario of acute pulmonary embolism, which is basically making the patient critically ill. Cough is something that is basically compensatory. The difficulty in breathing is leading the patient to cough desperately, and is usually a dry cough that the patient is suffering from. Now, again, the diagnostic factors. We'll be focusing on the fact that we have a lot of factors at our hand. For instance, chest X-ray is the mainstay over here. You would be looking for the different important features in the chest X-ray that are basically leading to the diagnosis of the pulmonary embolism. But before that, you'd be focusing on the 3 major diagnostic criteria that you have to focus on. First of all, the patient should have a complete clinical picture. Then the history is going to be associated with this particular clinical picture. Age group is going to be considered. What are the secondary conditions that the patient is suffering from? For instance, a lot of patients with congestive cardiac failure usually land up with this kind of a scenario of acute pulmonary embolism. So any kind of secondary scenarios are also going to be considered over here. Then secondly, we are going to focus on hypoxemia, that is the low levels of oxygen in the tissues. So this is basically the hypoxemia that the patient can suffer from, and that can definitely lead to another condition of hypoxemia, which is the lower level of the oxygen in the blood, less than 60 millimeters of mercury. So this is the cutoff point that you have to remember. So symptoms, the set of whole symptoms that the patient is suffering from. Along with that, the picture of hypoxemia. And then we have a pulmonary angiogram, which is quite diagnostic for these patients of pulmonary embolism. So these three features are going to sum up and make the essential diagnosis of pulmonary embolism in these particular patients. Now, one event leads on to another important cascade of event in this whole cycle of events that are taking place in pulmonary embolism. First of all, there would be an increased respiratory rate. Again, the patient is going to have an increased heart rate, that is tachycardia. Tachypnea and tachycardia go side by side in these patients of pulmonary embolism. Then as we move on, this tachypnea and tachycardia, that is the increase in the heart rate, the increase in the respiratory rate, is also going to result in the hypotension, that is an overall decrease in the blood pressure in the peripheral circulation. This decrease in the peripheral circulation gives an overall picture of shock, that is a hypovolemic shock in the patient. So again, it is very important to consider all of these complications in the patient of pulmonary embolism, and we should be well versed that we have to basically maintain the airway, maintain the breathing, and also have the two double-bored white cannulas passed in the patient to maintain the circulation and maintain the blood pressure for the patient, and basically stop the patient from going into a condition of shock. So this is the complications that you have to keep in mind, and you should be on your foot to treat these patients properly and make a proper treatment modality or a treatment plan for these patients of pulmonary embolism, and obviously move towards the definitive diagnosis of pulmonary embolism as well for these patients. How do you diagnose that this particular patient is definitely suffering from pulmonary embolism? What would be the particular criteria for the diagnosis in these particular patients? Now, the criteria would basically consist of all of these factors. First of all, the acute onset of dyspnea. So usually in patients, when you differentiate these particular patients from the patients of asthma or the patients of chronic obstructive pulmonary diseases and compare the history with these particular patients, you would get to know this point that the onset of dyspnea, the difficulty in breathing, was quite acute in its onset. When you would take the history from an asthmatic patient, he or she would be giving you a history that he developed the difficulty in breathing over a period of weeks. He had been suffering from this particular difficulty of breathing, and the cyanotic episodes would also be coupled up along with this difficulty in breathing in the history of asthmatic patients. On the other hand, the history of the chronic obstructive pulmonary diseases would again reveal that the condition basically developed over a period of months, and it can even prevail on a period of years. So this would be the particular history in cases of chronic obstructive pulmonary diseases. But in comparison, the patients who are suffering from pulmonary embolism would develop this difficulty in breathing over a period of hours. Maybe mostly it is usually less than 24 hours. The history would only be for less than 24 hours, difficulty in breathing would have developed to a critical point in these patients. Then this difficulty in breathing is also associated with a pleuritic kind of chest pain. So you have to differentiate between a dysphagic chest pain, you have to differentiate between a chest pain which is associated with myocardial infarction. We all know that a chest pain which is associated with myocardial infarction, it usually refers to the left shoulder, to the tip of the shoulder, or to the jaw. So this radiation is an associating factor in cases of myocardial infarction. The pleuritic kind of chest pain usually is only subjected to the sides of the thorax, and the lateral aspects of the thorax are usually involved in this pleuritic kind of chest pains. Then we have tachypnea, that is an increased respiratory rate, which is usually seen for these patients of acute pulmonary embolism. We have tachycardia, which is usually associated with these features of dyspnea. The patient is going to have a cough, a dry kind of a cough, which is compensatory in its nature. Pleuritic chest pain would be seen, and this increase in the heart rate, this increase in the respiratory rate is basically making the patient more prone to get into a complicated state in which the patient would get basically critically ill, and you would have to have the supportive treatment for these particular patients. The hypoxemia with widened A gradient is also seen for these patients. So this is the set of signs and symptoms that we were focusing on. As we said, we had the three major criteria for the essentials of diagnosis. That basically consists of a set of signs and symptoms, a set of clinical features. So this is the set of clinical features that we were focusing on. And when this set of clinical features is also associated, you conduct a pulmonary angiogram for these patients, and you also associate with the typical kind of the history in which the DVT could develop in the patient. The patient had past surgical history in which the patient got bedridden, and that can even lead to the event of DVT, and that can further on result in the ambuli to be dislodged towards the pulmonary circulation. And then we have hypoxemia, which has to be calculated when we conduct the arterial blood gases. So ABGs is something that you have to conduct for these patients. And this is again quite diagnostic for these patients, and it would be very helpful as an intensivist for you that you diagnose these cases and you conduct the ABGs accordingly for these patients. And that is basically going to distinguish between the asthmatic patients, the COPD patients, and the patients who are suffering from pulmonary embolism. There are a lot of predisposing conditions that we'd be considering on the events that we discussed, the underlying basic pathology that we discussed, the development of DVT, and the further on moving on of this dislodgement of the ambuli from the peripheral circulation towards the pulmonary circulation. The predisposing conditions could be when we just tabulate or when we just make flow charts, it is easier to remember the cascade of events, the different conditions that can lead to the same kind of cascade of events. So over here, venous stasis is one of the major factors that we already discussed. So whenever there would be the stasis or there would be pooling of the blood in the peripheral circulation due to any reason, that would be one of the major events that can take place and that can lead to the complication of pulmonary embolism in these patients. Venous stasis can basically result from the immobility, a prolonged kind of immobility due to any reason, due to surgeries, due to any other major ailment that the patient is suffering from. A lot of psychopathologies can also result in the immobility in the patients, and even that can result in the venous stasis. So any scenario that is resulting in the stasis of the blood in the peripheral circulation is leading to the development of pulmonary embolism. COPD is one of the scenarios that we can consider. Then we have congestive heart failure, and that can again result in the venous stasis. Why is that so? Because when the heart is not pumping enough, the left ventricle dysfunction is present in the individual. That can result in the backflow pressure towards the pulmonary circulation, and that is again going to result, or that can basically dislodge ambuli from the heart itself, from the valvular ambuli, or the valvular thrombi can basically dislodge towards the pulmonary circulation. The backflow is basically the causative factor over here. Then we have the venous endothelial damage. So this can be another scenario. We have the stasis of the blood that can result in this particular scenario, and then the endothelial damage is basically leading to the development of the thrombus formation. So whatever event that is resulting in this endothelial damage can again give rise to the complication of pulmonary embolism. So there can be the surgery within past 3 months which led to the endothelial damage. Any kind of surgery can lead to this endothelial damage, and then we have the fractures of the long bones or the hip, which basically make the patient immobile as well. So it is basically the collection of venous stasis as well as the venous endothelial damage that is occurring for these particular patients. And then we have burns that can basically make the patient immobile as well, and that they can also result in the endothelial damage, that is the venous endothelial damage in the patients. This is the particular scenario that we are considering. And then we have the lower extremity trauma. And then specifically, we have the states of the hypercoagulability. So there can be the blood disorders. The blood itself can lead to these particular kind of disorders of hypercoagulability, which is leading again to the thrombus formation, or the emboli can then form by these thrombus when they are getting dislodged from the peripheral circulation. Then they are ultimately resulting in the pulmonary embolism. So this is some kind of scenarios that you have to consider. The hypercoagulability states. What are the hypercoagulability states that you have to consider? It can be a malignant neoplastic disease that is leading to the hypercoagulability states. Then we have the use of oral contraceptives. So usually the patient is going to give you a detailed history regarding the use of oral contraceptives. Again, you have to focus on the fact that history taking is very important. If you want to point out any kind of a trauma that the patient had undergone, if he or she has surgery within the past 3 months, any major surgery that she had undergone, so the surgical and the medical history, along with the drug history, any kind of prolonged use of oral contraceptives that can be highlighted while you're taking the history from these patients. Marked obesity also makes the individual immobile. It also results in the hypercoagulability states. So there are these two underlying pathologies that are linked up to the obese individuals. We have protein C and S deficiencies that is again going to lead to the hypercoagulable states in the individuals. Antithrombin 3 deficiency is again going to lead to a cascade of events which is leading to the particular thrombus formation in the vascular walls, and again leading to the particular cascade of events. And then we have the presence of the factor V Leiden. So this is again one of the important conditions that you have to focus on. And then we have the previous history of the deep venous thrombosis or pulmonary embolism, which is again going to make the patient more prone to the development of pulmonary embolism. Usually you would get these patients who had recurrent attacks of pulmonary embolism because they were already diagnosed with COPD or protein CNS deficiencies, or factor V Leiden was found in these patients. So already you have a lot of workup at your hand, then it's quite easy to diagnose in these particular cases. But these predisposing conditions have to be kept in mind, and you have to rule out these conditions when you're taking a detailed history from the patient and document them down accordingly for even further analysis and further assays for the patient. The signs and symptoms for these patients are dyspnea, that is the difficulty in breathing, which is noted down. And then we have chest pain, which is moreover pleuritic in nature, particularly. And then we have tachycardia, which is also seen in these patients, that is the increase in the heart rate. The patient would be suffering from hypoxic condition, that is the tissue levels, the tissues won't be getting enough oxygen. Even there would be marked cyanosis in the peripheral circulation. The limbs would be cyanotic, the tips of the fingers would be cyanotic, the tip of the nose could be cyanotic, and these are basically relaying to the fact that the patient is going into hypoxic condition. Fever is sometimes associated. Now, why is fever present? It's just the embolus that traveled to the pulmonary circulation, because it is leading to an inflammatory reaction as well. It can lead to the infectious state as well, and you have to basically, even it can be an overlapping factor. Sometimes the pulmonary pneumonias or any sort of infections are sometimes even associated along with this pulmonary embolism. So fever has to be seen, and usually they are suffering from a mild to moderate kind of a fever. Hypotension, the patient is usually going into a shock due to all of these cascade of events that are taking place. Cyanosis is one of the factors that is again seen in these patients, particularly in the peripheral circulation. And when you auscultate the chest of the patient, there would be the pleural friction rub as well. And these are the sounds, the auscultation sounds that you have to look for. And then the pulmonary consolidation is also looked for. Permanent damage to the lungs can occur, pulmonary fibrosis can occur, and that would be basically, you can even see that when you perform percussion on the patient, that is going to give you a dull sound on percussion. That is basically pointing out towards the pulmonary consolidation. So all of these symptoms, as well as the set of signs, they are looked for when you have these patients. The laboratory and the other findings that are quite conclusive of the fact that the patient is suffering from pulmonary embolism, they basically include the chest X-ray. Two of the most important signs that you have to look for are the Westmark sign, and then we have the Hampton's hump. It's again very important that you look for these particular features, and they are diagnostic for the pulmonary embolism. Then we have the ECG. ECGs are usually abnormal. There is ST abnormality that is usually associated with that. And whenever you get an ECG that shows some kind of pathologies, you would be performing the ABGs for the patient as well. The arterial blood gases and the gas counts are taken into account. You would be looking for the D-dimers as well. And along with this D-dimers, you are going to make a Geneva scoring as well for the patients. And this Geneva scoring and the D-dimers are quite conclusive when you are making the diagnosis of pulmonary embolism of these patients. Now, regarding the Geneva scoring, it's usually variable. It includes the factors such as age, which has to be more than 65 years. Then we have a previous DVT in episode or previous episode of pulmonary embolism also scores towards the Geneva scoring. Surgery or fracture within 1 month. And active malignant conditions currently active or considered cure for less than 1 year. Then again, unilateral lower limb pain is considered, you would be considering any history of hemoptysis, that is sputum tinged with blood. So coughing of blood is one of the factors that can be quite diagnostic in cases of pulmonary embolism as well. And then we have a heart rate, usually 75 to 94 beats per minute. And moving on, we have a heart rate of more than or equal to 95, which is again diagnostic for the Geneva scoring. Pain or lower limb, pain in the lower limb, and then we have the deep venous palpation or the unilateral edema on either side of the limbs. That can be again quite diagnostic for the pulmonary embolism. All of this basically should make up to a score of, it basically counts up to 1. Any of these factors is basically scoring for a 1, and a score of more than 6 is basically referring to the fact that the patient is suffering from pulmonary embolism. The diagnostic imaging would consist of contrast-enhanced CT scans, and then we have the ventilation perfusion radionuclide lung scans. That would again give you the idea that the patient has some sort of a vasculature abnormality. Venous Doppler ultrasounds would predict that the patient had been suffering from DVT or not. And then we have the pulmonary angiograms. So all of these are basically diagnostic, and when you couple up all of these scenarios along with the set of signs and symptoms and along with the detailed history, it is going to be very easy for you to diagnose that the patient is suffering from pulmonary embolism. The treatment would consist of patients with acute pulmonary embolism have to be put on the anticoagulation therapy. And then we would be considering the hemodynamic instability in these patients as well. If the hemodynamic instability is present, the patient is going into a state of shock and it is a high-risk patient, you would be considering the reperfusion treatment as well for these patients, the hemodynamic support. You would be passing on the double bored cannulas and maintaining the blood pressure and preventing the patient from going into a shock kind of a state. Distinguishing the low from the intermediate risk factors, and you would be looking for two major factors. If any one of these is present, then it is basically a high-risk patient. The clinical signs of P severity are taken into account. It has to be a patient of serious comorbidity as well as for instance, you're going to consider whether the patient is suffering from heart failure or not. The age of the patient is taken into account, whether he or she has undergone any kind of a surgical intervention or not. Second most important point is the right ventricular dysfunction, TTE or CTPA are also taken into account. And if any one of this condition, the right ventricular dysfunction is present, we're going to perform the troponin test. It's basically the cardiac enzymes that you're going to look for, and then you're going to monitor and consider the rescue of the perfusion can be performed, and if the patient is deteriorating, you're going to hospitalize the patient in any one of these conditions. If these comorbidities are not present and there is no other reason for hospitalization, family or social support is also not present in the hospitals, and if there is an easy access to the medical care, even then sometimes you can go for the hospitalization, and sometimes you can resort to the early discharge and consider home treatment for these patients. So this can be the whole criteria, the treatment plans that you're going to consider for the patients of pulmonary embolism. Now, moving on with this particular clinical condition, which is basically coughing up blood, is a condition which is known as hemoptysis. So it can be even tinging of the sputum, which can be also considered as hemoptysis, and usually coughing up enough blood, almost 200 cc to 600 cc, is considered to be diagnostic for hemoptysis in the past 24 hours. Now, the history is again very important over here, and you're going to look for the particular features which are basically pointing out towards this particular condition. You would carry out the whole physical examination, and usually the positive points that you would be looking for in these particular patients are the signs of anemia, because usually a lot of conditions, for instance, it can be tuberculosis, it can be a lot of malignant conditions, it can be the infectious states. The tuberculosis, for instance, mycoplasma can basically eventually lead to the development of this condition of hemoptysis in the patient. So you're going to look for the history as well as you're going to perform the physical examination, a detailed physical examination in these patients, looking for the signs of anemia or looking for the features which are basically diagnostic in their factor. And basically you're looking for the cause which is resulting in this particular scenario of hemoptysis. Now, the suggestive of gastrointestinal source. So again, it's very important that you have to basically distinguish this condition of hemoptysis from hemoptysis. So these are the two distinguishing scenarios Hematemesis is basically blood in vomitus, and hemoptysis is coughing up blood. So these are the two distinguishing scenarios, and sometimes when the patient coughs up the blood, it goes into the esophageal tract, and then he or she also vomits out blood. So sometimes it is an overlapping picture, but you have to be quite sure what is the origin of the bleeding. This is again very diagnostic over here. The suggestion of the gastrointestinal source is when you conduct the ENT as well as the GI evaluation for these patients. All of the gastrointestinal tract, you can even resort to endoscopies in these patients to rule out any factors that are leading to the hematemesis that can basically point out towards the hematemesis or the episodes of hematemesis in the patient. And then the signs that are suggestive of the lower respiratory tract sources, they are also looked for in the patient. You can perform chest x-rays, and if it is a normal chest x-ray and there are no risk factors for cancer and no history is suggestive of bronchitis, sometimes we can have the history suggestive of bronchitis with no risk factors of cancer. All of these scenarios are taken into account. It's basically the history and the physical examination which is coupled up along with the lab investigations, that is the chest x-rays that are performed. And when you have all of this evidence at your hand, you can basically relate to the factor either it is bronchitis or either it is some sort of a neoplastic condition that is resulting in hemoptysis. So you have to observe the patient, and sometimes you resort to even bed rest in these patients. You plan for cough suppression with an appropriate opiate that you can prescribe to the patient. The bleeding sometimes ceases, and there is a cessation of bleeding, and you can have no further evaluation in these cases if you have ruled out neoplasms, if you have ruled out all the serious causes. You can just discharge the patient as well. The recurrence of hemoptysis is seen in a lot of patients, and the risk factors of cancer are also evaluated for these patients of hemoptysis. On chest x-ray, if it is not a normal chest x-ray and you find a mass that is present, and there is a recurrence of hemoptysis as well, you can perform or you can resort to further evaluation by performing bronchoscopy, or you can also resort to CT scans in these patients. The patient can also suffer from other parenchymal diseases, and for that, the diagnostic factors would be CT scan. No specific diagnosis is there, then you can resort to further evaluation again by bronchoscopy or CT scanning. If there is a specific diagnosis, you would be focusing on the suggestive diagnosis and you would be conducting the other regular tests as well. So moving on, we have another important pulmonary emergency that we sometimes should be dealing with, that is the pulmonary arterial hypertension. What usually causes this pulmonary arterial hypertension? The exact factors are quite unknown, but there is a hypertension that is associated in the pulmonary circulation. It can be the congestive heart failures, or it can be other comorbidities that can exist in the patient. Smoking is usually the patient is usually seen to have a history of chronic smoking as well, who's suffering from pulmonary hypertension. Patients with liver diseases also end up in this condition of pulmonary arterial hypertension. The essentials for the diagnosis of pulmonary arterial hypertension would consist of the exertional shortness of breath or syncope, that is the lowering of the blood pressure. The absence of the congestive changes on the chest x-rays are also noted down in these patients. And then we have a loud pulmonic closure. P2 sound is audible on auscultation of the chest. So these are the three major diagnostic criteria that make it easier for us to diagnose the cases of pulmonary arterial hypertension. The imaging and laboratory findings would consist of the ECGs, the echocardiographs are also taken into account, And then we perform the Swan-Ganz catheter test just to see any kind of abnormality, if there is some sort of a right ventricular dysfunction, there is any sort of ventricular dysfunction in the patient that is diagnosed by this Swan-Ganz catheter testing that is performed. The treatment usually consists of phosphodiesterase type 5 inhibitors, and then we move on to the prostaglandins as well, that are basically the drugs of choice. Pneumothorax is one of the condition as well, and the essentials for the diagnosis would consist of the history would consist of a paralytic chest pain, acute onset of dyspnea, decreased breath sounds on affected side, and the evidence of the lung collapse on the chest x-rays. The tension pneumothorax is distinguished by a displaced PMI, and then we have a shift of the trachea and a jugular venous distension. So again, the JVP has to be calculated for these cases of tension pneumothorax. The signs and symptoms would consist of a severe respiratory compromise, and tachypnea is one of the features seen in these patients, that is the increase in the respiratory rate. Shortness of breath is noted down. We have the breath sounds diminished on the affected sides as well. Pleuritic kind of a chest pain is associated with it. Cardiovascular collapse is seen in these patients. And we have a tracheal mediastinal shift that is seen in these patients as well. The displacement of PMI to the opposite side is again noted down in these particular patients of pneumothorax or even the tension pneumothorax. What are the imaging techniques that you're going to resort to? First of all, the chest x-rays to note down any kind of a mediastinal shift. And chest CTs are even going to relate to the air in the pleural cavity, and that is again diagnostic for these patients of pneumothorax. The treatment would obviously consist of, if it is a spontaneous pneumothorax, ages more than 50 years and significant smoking history, or if there is an evidence of underlying lung disease on examination or chest x-rays, then it is a primary pneumothorax and the size is more than 2 centimeters or the patient is breathless. You have to aspirate the patient 16 to 18 G cannula. This is the bore of the cannula that you're going to use for the aspiration, and the aspirate should be almost less than 2.5 liters. So this is the surgical intervention that we can resort to. The success size would be if it goes from more than 2 centimeters to a size of less than 2 centimeters. So if it is a yes and you are successful in basically aspiration of the air, you'd consider the discharge and review in the OPD in 2 to 4 weeks. If it is a secondary pneumothorax, you would be, and there is more than 2 centimeters of air, the patient is breathless, he's dyspneic. The size is almost 1 to 2 centimeters and the aspirate is 16 to 18 cannula boring is used and the aspirate is less than 2.5 liters in this particular case. The success size would be if the size would go up to less than 1 centimeters. And if it is more than 2 centimeters in size, you'd be using a chest drain for these patients because then you cannot drain out through a cannula. Size of the chest drain would be almost 18 to 14 and you would be basically admitting the patient and it is basically a hospitalized procedure and the patient has to be under observation as well. Then if the size is almost, it regresses to less than 1 centimeters or you can sometimes admit the patient and just follow up with the high flow oxygen and give the supportive treatment to the patient and just observe the patient for more than 24 hours and then decide what can be the further intervention that you're going to perform, whether it is a chest drain or either you can even resort to the cannula aspiration. The pneumomediastinum consists of the signs and symptoms of the physical signs such as Hammond's crunch. We have a radiological signs in which we have lucent streaks of gases seen in the mediastinum. Air can go into the mediastinum in any cases of trauma, and treatment is directed at the underlying disorder. Either it is a trauma or either it is some sort of a disease process that is going on. You have to treat the underlying cause to get the required results in the patient. Pleural effusion is basically the collection of fluid in the pleural cavity. So the history is very important, and you would be focusing on the physical examination as well. Just to have a definitive diagnosis, you would be performing the radiological imaging for these patients. Diagnostic thoracocentesis and performing the thoracic ultrasound is done. The diagnosis is made according to the radiological imaging techniques. You're going to perform the thoracic CT scans, and we can have the transparietal pleural bioscopy or even a thoracic ultrasound is resorted to. We can have different diagnoses. For instance, we can have transudates, chylothorax, empyemas, that is an infectious fluid if it is collected around the lungs, and we can have even the collection of blood in the pleural cavity. Bronchoscopy is performed, and accordingly you can perform or resort to the other tests supporting the diagnosis. And according to the diagnosis, you can treat the underlying cause, and also you can perform thoracotomy for the patient. It is basically the most appropriate surgical intervention that you can perform. Again, when you have a definitive diagnosis, and then it is very simple, and then it is very easy to basically monitor these patients, and accordingly you can treat these patients. But if you are still confused, you can again perform bronchoscopy and the diagnostic evaluation tests for the further management of the patient. After thoracotomy, you have to basically keep the patient under observation for at least 24 hours. So in this lecture, basically, we summarize the different emergency treatments that you can resort to when you have the patients with different diagnoses at your hand. It can be a pulmonary embolism, it can be a pulmonary arterial hypertension that you're treating. But you should be well versed with the management plans and how you're going to work as an intensivist to basically take care and provide the life-supporting treatment to the patient. That is the end to this lecture. Thank you for watching sqadia.com.